All right, so we're going to go into the lower respiratory and upper respiratory drugs. First, we're going to go with the upper respiratory, but prior to that, it's very, very important to have an understanding of this little chart that I made. We'll provide I understand that there might not be good light here, well, because it's all shined on, but we're going to provide the slides so you guys can follow along and we could just go ahead and get started. So, a lot of these drugs, we start seeing a lot of this, the phrasing anticholinergic. We have this whole bronchoconstriction that needs to be dilated because if not, we can't breathe. So, it's really important to understand what's going on right here, right? So, all in all, our respiratory drive is mainly controlled by our autonomic nervous system, right? And our autonomic nervous system forks out and is the sympathetic nervous system and the parasympathetic nervous system, right? So these are some very important characteristics of sympathetic nervous system activation. We have our bronchodilation, we have no digestion, we have vasoconstriction, pupil dilation, which will come up soon, why that's important, and then high blood pressure and high heart rate. So, and it's also that the vasoconstriction influences the high blood pressure as well. And so this is fight or flight. We've established that, right? And this over here, the parasympathetic, is us resting and digesting, right? Because now we're actually digesting. Um, we're not really panicked anymore like we are with the sympathetic nervous system, so we can go ahead and not have the airway so open, so we can constrict the bronchus. So that's why bronchoconstriction occurs. Vasodilation occurs, right? Because now we don't really need to be worried. We don't need to have too much pressure going in through our vessels to perfuse us. So the pressure goes down with vasodilation. Pupil constriction also goes down because you don't need to take in a lot of information, and the heart rate also goes down because there's no more epinephrine going in through, right? In the end, we could scroll up just a little bit. We have this stuff I have right here that I made in green, which is it. The parasympathetic nervous system allows for cholinergic effects. So whenever you hear cholinergic, I want you to think about the parasympathetic nervous system. Now, it's not saying that they mean the same thing, it's just that one influences the other. So they're tethered, but they're not the exact same thing. But usually, things that kind of stimulate something like this will have some kind of effect going on over here, and it could be vice versa, but mainly this can have some kind of effect or side effect, I guess you can say, of over here. The same way how on the other side of the spectrum, um, the sympathetic nervous system has anti-cholinergic effects. So it's halting any cholinergic activities. That is all this in green right here. Might be a little hard to see, so again, take a look at your slides, but I'll say it out loud. So cholinergic effects are practically anything that really is allowing there to be secretions occurring in the body, whether it's something you can see inside, or I mean, I'm sorry, something you could see outside, like sweating, a person making tears, saliva, urine excretion, bowel movements, mucus production, and vomiting. All of those things, I want you to associate it with cholinergic effects. Some things you can't see would be exocrine secretion. So basically, one of the drugs that we talked about in the past chapter was pancrealipase, which is a replacement drug for um, pancreatic enzymes that you use to digest stuff, right? So this is what occurs when you're in resting and digesting, right? So now we're forming connections, right? So if you're able to digest, you obviously need to have some kind of exocrine enzymes going into the small intestine so you can digest all your food, right? But when you are in, for whatever reason, fight or flight, right? You need to. Can you go ahead and bring it back down a little bit? So you need to have a sympathetic response, right? You are panicked. You need as much air. You need to think clearly. Your your bronchioles are gonna dilate, right? Because they're going to increase the diameter, right? So they're going to allow for more air to come in. That air is going to help you perfuse. It's going to help you think much more clearly, especially in emergency situations, because that is what you need, right? It's life or death. So you need as much air as possible. Are we going to be digesting at the time when we're really panicked? Probably not, because that can wait. That is not paramount right now. We need the vasoconstriction again because we need very strong pressure to perfuse our tissues everywhere in the body in order for us to run away from whatever danger is going on. The pupillary dilation occurs because as you're in a very panicked mode, you need to take in as much information as possible. So the way we get information is because of our pupils dilating, right? That's the reason why when you step into a dark room like the one we're in, typically your pupil will dilate because you need to take in as much light as possible in comparison to when you're outside and there's no need because it's clear in the environment. And then the heart rate goes up too because of the epinephrine release. So in that case, in these situations, when you're in fight or flight, life or death, your body is thinking, well, I'm not sure how long I'm going to be panicked in, so I don't really want to be forming any tears. I'm not going to be forming any sweat. I'm not going to be urinating. I'm not going to be doing anything right now. I'm not going to be having bowel movements because I'm going to shut down my digestion for a little bit, but I don't want to make tears. I don't want to sweat. I don't want to make urine go outside because I need to hold that in because I don't know how long I'm going to be panicked for. So I need to reserve as much water as possible, right? Because water is one of the most important things in our body. So the whole reason why I made this chart is because these drugs, a lot of these drugs that we're going to get into, they have a lot to do with these kind of things, right? And to kind of tailor it better to this chapter, whenever you're undergoing a time when you're making too much mucus, right? Like in the end, we're going to be talking about allergic rhinitis, which has you make a lot of congestion with all the mucus buildup. Usually that's because your blood vessels in your nose and also blood vessels later in the chapters that we're going to go into in the lower respiratory tract, those vessels are pretty dilated, right? Because they're forming a lot of immune response, right? Mucus is basically an immune response, right? Because we want to use that mucus to catch whatever pathogens, filter air, especially through the nose, the little hairs that we have. But the mucus helps catch dirt, pathogens, or whatever. But in order to have that, you need to have your blood vessels dilated, so it has an easier travel time to get to the nose. So more secretions. Again, look, cholinergic effects. The mucus production that goes hand in hand with the vasodilation. So a lot of these drugs happen to initiate the sympathetic nervous system because look, vasoconstriction occurs, right? And then if we're halting any cholinergic activity, you're not really secreting your mucus that you're supposed to be secreting. It also kind of shuts down a little bit of inflammatory response as well. But that kind of is a little bit more tailored towards drugs that actually immunosuppress completely. But it happens where everything gets shut down, right? Because it's still one part of your immune system, the mucus that we were talking about. So whenever you have a little bit of trouble forming the connection later in the slides, always look back at this one because this will give you a clear understanding of what is going on. This is going to help so much when understanding why is it that this drug, what does this mean? What does this cholinergic mean? What is anticholinergic? Why is this occurring? Why is this patient having these side effects when they just took a drug that's only supposed to stop cholinergic activity? The reason why is, again, they're tethered to the sympathetic nervous system, and you will see that as we go on. So now with that, we could go ahead and move on to the next slide. Right? One more? Okay, cool. So as mentioned, we are in chapter 39, so these are all drugs relating to allergic rhinitis and the common cold. So it's basically, as the professor said, anything above the clavicles. So we're going to move down. All right, thank you. So, I mean, long story short, we don't really need to get too crazy about the respiratory tract, right? In the end, we have known that the air, all the turbinates we have in our nose, those things just help kind of humidify air, make it warmer, make it clearer for our lungs to take in and, not be cold air going into your lungs because that might irritate. Another thing too is, again, activation of the sympathetic nervous system constricts the arterioles in the nose, right? This is going to be that anticholinergic effect, right? Because if we have dilated blood vessels in our nose, that's going to cause the mucus production. It's going to assist with it, right? So if you initiate the sympathetic nervous system and constrict arterioles, you're making everything drier. You're not making the mucus that you're supposed to be. And again, I mean, prevents particulate matter, right, with the little hairs we have in our nose right here, and then also mucus. And then obviously it's the first line of defense, right, because after all, it's pretty much where air first enters, right? So that's kind of uh, pretty common knowledge that. So we can just move on to the next slide. Nothing too crazy about it, right? So allergic rhinitis, right? The biggest characteristics that are ongoing are the sneezing, the watery eyes, and the nasal congestion. So the nasal congestion occurs, right, because of that immune response in response to the sneezing and watery eyes, right? So first and foremost, sneezing, watery eyes are all related to the release of histamines. Histamines are what makes you have an allergic reaction, right? Now, you can have a mild allergic reaction, which is kind of what's going on with allergic rhinitis, or you can have a severe allergic reaction, like with, how do you say it, anaphylaxis, right? So it has a broad spectrum, right? So mainly, that release of histamines will cause you to get to sneeze and have watery eyes. And because all that histamine has been released, generalized right in your face, right, where your sinuses are and your nose, since there's that histamine, which histamines dilate your blood vessels, right? And then they allow for more leukocytes, they could be whatever, but those leukocytes will produce nasal congestion. They'll assist with mucus production. And that is the reason why. So these are it's the reason why the congestion is tethered to the watery eyes and sneezing. We're going to talk about how some drugs will only really treat the congestion, but not really treat the sneezing and watery eyes. So they have to be used with combination of a antihistamine. The most important thing, we need the antihistamine because the antihistamine is the cause of the problem for the most part. The immune system is the cause of the problem, right? Because that's what allergies are after all. In the end of the day, we're supposed to be fine, right? Like you're not really supposed to be allergic to, for instance, I don't know, dog hair, peanuts, something like that, right? You're not supposed to be, but your body for some reason just doesn't like it. So it produces some kind of immune response. So it's not really your body that is, panicked because you took in some kind of foreign antigen. It's because your body's just inappropriately responding to that antigen, right? And there it is right there. The allergen, right? The antigen. It's the same thing in the end. And there you go. Causes the histamine release that causes this stuff over here. So we could go ahead and just move now. Okay, so there's really only two ways to really kind of work on this type of stuff when it comes to allergic rhinitis, right? There are preventers, which are going to be the most ideal thing to really do because this will help you in the long run. But there are also relievers, right? So relievers are meant to treat when it's pretty bad and you want immediate relief, right? I mean, after all, that's why it's called a reliever. Preventer, funny enough, like the name says, it's prophylaxis, right? So in the end, it's the best way to treat allergic rhinitis for using a prophylaxis, right? It's the same thing that we learned with the Stelmavir about the whole, um, what's better, take Stelmavir or get the flu vaccine? And in the end, it was said that it's just recommended to get the vaccine for prophylaxis better than actually taking the drug because, long story short, doesn't have a great effect. The same thing that we're going to learn about these decongestions. They don't exactly have the most, efficiency. But long story short, right, these prophylaxis drugs, typically they are antihistamines, right? They are going to be our intranasal corticosteroids, and they're going to be mast cell stabilizers. Now, another drug that is not mentioned in this slide, but it is possible to treat allergic rhinitis, are leukotriene modifiers, but they're not usually used for allergic rhinitis, but they can be. It just, again, those kind of carry a different kind of consequence of use. So usually these don't have a lot of crazy side effects. I mean, this one does, the antihistamines, but generally the other ones, they kind of don't, so they can use they're very well with being used chronically. As for the relievers, again, they only really treat for the moment. So the whole problem is that just like other drugs that we've learned, right? The faster the onset it is, like an antacid, right? The antacid treats a peptic ulcer not directly, but it just evens out the heartburn, the epigastric burning, but it only helps it for a moment, right? Because after a while, it goes away. The same thing happens with these intranasal decongestants and oral, you could say, but the intranasal decongestants, they will treat it for a moment. They're a band-aid. Long story short, they're just a band-aid. The preventers will be helping out in the long run, but the relievers are just a band-aid for a problem, right? And in the end, they do this specifically because they do that sympathomimetic action. So what sympathomimetic means is legit, you are stimulating just like how we had on this side of the board, all the way up there, we had um, we had the sympathetic nervous system and all the characteristics that go with it. Beyond that, we could just move on to the next slide. So we're going to get into histamines, right? So there are two different histamine receptors, right? There's histamine 1, which we have learned is mainly tailored to our respiratory system. So I guess in a way to kind of remember it, histamine 1, think of like what is one of the most important things in our body, right? Breathing, for the most part, right? Your brain can't really go on without some 6 minutes of air without having significant damage, right? Histamine 2 is everything relating to the GI tract, right? So for the GI tract, like what's more important, breathing or digesting, right? Breathing, yeah? So histamine 1, think what's one of the most important things? Breathing, right? So this has a lot to do with our respiratory system. It's not that it influences our breathing, it's just more it's the immune system responding to the respiratory system, and then histamine 2 responding to the GI tract. In the end, it helps out with everything going on here, right? And then usually the respiratory tract is smooth, it's very vascular, so it contains a lot of blood vessels, and that stuff will help us when we get down to stopping things like congestion and allergic rhinitis, and then down, all the way down in the lungs with how do you say it, COPD and your asthma and whatever. So we'll just move on to the next slide, right? Okay, so we have our H1 receptor antagonist, right? So the main thing that needs to be known is that the prototype drug, kind of like the first generation drug of its kind for antihistamines, is diphenhydramine, right? And the trade name for that is, funny enough, look at that, Benadryl. Benadryl is probably one of the most well-known drugs out there, right? Unfortunately, in these past couple of years, it has had an increase of abuse, and we will find out why it gets abused. But long story short, the mechanism of action, right? Antihistamines, right? The diphenhydramine is an antihistamine. What might the mechanism of action be? You're legitimately just blocking H1 receptors. You're preventing histamine from being utilized and being released, right? Because you're shutting it off. If you turn off those histamines, right? What's going to happen? You're not going to be producing all those leukocytes to go to where they need to go, right? You're not going to be allowing mucus production. You're going to lower everything, right? Which is really good. That's what we want, right? So again, it usually treats minor symptoms of the allergy and the common cold, right? Because what happens when you have the cold, right? You get all like you're all constantly making like noises with your nose, right? And you're like you sucking back up the mucus and stuff. So that's why it helps out for the common cold. There are a couple other extra uses that they can be applied to, but we'll touch on those in a little bit. So adverse effects, right? So this is actually one of the biggest reasons why it is commonly abused, right? Because antihistamines, especially diphenhydramine, the later generation drugs don't really have the same effect, but this Benadryl causes a lot of this. It causes drowsiness first and foremost. Funny enough, when you get exposed to it too much, the drowsiness effect actually diminishes. So you get kind of desensitized to it, right? But every now and then, usually it's always associated with like CNS, not really depression, but like hallucinations, kind of like an alterated state of mind where you basically get high with the drug if you take very high dosages of it. Funny enough, usually it kind of calms your body down, but the interesting about Benadryl is that it can go both ways. It can either excite your body or it can down your body, which is interesting. Um, in the end, mileage varies on every patient. Um, so here's where this is going to need that parasympathetic, sympathetic nervous system stuff to help us understand what's happening, right? So we had anticholinergic effects, right? And that's what I wrote down on this side with the sympathetic nervous system, right? So if you can maybe pause the video and then try to remember without looking here what's going on, we can go ahead and once you come back, we can see that, right? So dry mouth. Why would that happen, right? Anticholinergic. We said over here on this side that cholinergic effects is basically allowing anything that is secreting out of your body, whether you can see it or you can't. So your mouth gets dry because you're not producing saliva anymore. Because a cholinergic effect would produce saliva in your mouth. But because an antihistamine has the action to preventing histamines from doing their job, and also they have an anticholinergic effect that causes a dry mouth. The tachycardia, why does that happen? What did we say in the beginning? We said that anticholinergic effects are tethered to the sympathetic nervous system, just the same way how a cholinergic effect is tethered to the parasympathetic nervous system. So it makes us wonder, whoa, why are they all tachycardic? This is the reason why. Because the anticholinergic effect of preventing everything from being secreted also kind of excites the body because it's part of that sympathetic nervous system. So always refer back to that first slide. Move the. Oh, okay, never mind. Yeah, move back to that. So again, always go back to that first slide. So there's the mild hypotension, right? That part's a little interesting because it isn't really part of the how we have our stuff going on, right? But it's kind of something that just always refer back to the drowsiness that occurs. I guess it's a little weird. I guess the hypotension we could say vasodilation, right? Oh, wait, pause it real quick. All right, that part was a little confusing in terms of the hypotension that I kind of overlooked, but I guess that's just something very unique about Benadryl. It just happens to be a drug that can cause mild hypotension in some patients. We looked it up right now in the book. Um, it's kind of odd because usually tachycardia, I mean, it could be in response to the hypotension, right? Because usually the drop in volume requires more pressure to be applied. But I guess that's just something very unique to it. So maybe try to remember that as well as you can. At least in terms of the photosensitivity, that is congruent with what we were talking about. The photosensitivity, again, we said that it's part of the sympathetic nervous system. We're in fight or flight. We need to dilate our pupil, right? We need to open it up as much as possible to take up as much information as possible. So the reason why you get the photosensitivity, like have you ever been in a dark room, right? And then you step out into a bright room and it like kind of blinds you, right? That's because your pupil is very dilated at the time you were in the dark room, heading into the very lit up bright room, right? Because all that information, which is light, is hitting you all at once, which is kind of overloading you. That's why you like respond by closing your eyes, right? So long story short, Benadryl would have a histamine blocking kind of activity, right? Especially mainly with the first generation drug, will start causing things with the central nervous system, like alterations like drowsiness. But it could also cause excitation, which is it's called paradoxical because the main intended effect is to kind of not really depress your body, but like lower your body. And sometimes bad effects happen where it does the opposite of the intended effect. That's where the paradoxical stimulation comes in, right? Because this isn't supposed to be happening, but it happens. Um, Again, so it has antihistamine action and it also has anticholinergic action. So it prevents the secretions from being made, right? So you're going to have a dry mouth. They're gonna dilate your pupil, right? Because you're going to take in more information because you're now in fight or flight, if you look at it that way. And then the you get that photosensitivity, you get the tachycardia because again you're in sympathetic mode in a way, so that makes your heart race. As we mentioned over here, we had tachycardia on that first slide with the sympathetic versus parasympathetic, right? And then I guess something very unique about it with some patients is that it causes mild hypotension in some patients. Again, that's pretty unique. I would have thought it was the other way, but it just happens to do that. So we could go ahead and just scroll just a little bit up, right? So right here, very little, like it's almost something you can kind of overlook, is this is just a later generation antihistamine. It's phenylphenidine, right? Allegra, which is basically a drug that we commonly seen a lot, right? And Allegra is it's a common drug, right? So this is just what's referring to this as a later generation drug is that all it's saying is that typically something of later generation, right? Like we talked about in the PUD chapters, right? There's certain first gen drugs have a lot of side effects, especially bad ones, but the later gens don't have as much. That's what this is referring to. This is same action, really, same action. Even possibly the drowsiness, but not as strong drowsiness. That's why it's not really a main use for that. But or for like sleep deprivation or whatever. But it's going to have the same effect in the end of the day. So maybe a possible question would be like, oh, a patient, what do you call it? A patient happens to, um, like they're reporting that they're having too much drowsiness with Benadryl. What would be another drug that you can give them? It would probably be the fexofenadine, the Allegra, because that has less effects. We can now move on to the next slide. So now we're going to talk about a little bit more specific things about Benadryl, the diphenhydramine, right? Scroll up a little bit more. So I mainly highlighted a little bit, like a lot more if you want. Right there, right there. That's good. So I mainly highlighted the most pertinent information, really, that I've noticed, right? Again, this is repeating about the helps with allergy and the common cold. It is combined with analgesic, decongestion, and expectorants, and we'll get into what that is later, in OTC cold and flu products, right? And it makes sense because in the end, this is what's driving that mucus production. We talked about earlier, right? Decongestants will treat the congestion, but they won't really treat the watery eyes, like kind of pressure buildup in the face because of all the histamines and stuff. They'll only treat the mucus in it, the congestion. That's why they need to be used in combination with these other drugs that will help with that, right? Because I mean, you can get rid of the mucus production with a antihistamine, but it won't give immediate relief. That's why you use a decongestion, right? Because we said decongestions cause immediate relief, but it just doesn't give a long relief, right? Another thing too, the uses of this drug, they can be given for severe allergic reactions. And we'll get into anaphylaxis later, but we'll kind of touch base a little bit on this one, right? It makes sense that you would give this either IM or IV because in the end, we said an allergic reaction is just an inappropriate response of your body's immune system stimulating a lot of histamine release. So in the end, the cause of the problem is all the histamines that were released, right? The epinephrine that we're going to give is going to help vasoconstrict, but the main issue, right? Obviously, first save their life, give them epinephrine. But once that's situated, because it's possible, because the epinephrine is like a band-aid, the cause needs to be addressed as well, and that's where that whole severe allergic reaction gets also IM or IV. Benadryl, right? And here's those additional uses, right? Parkinson's disease, right? Motion sickness. We talked about in our lower GI chapter about drugs that can help with motion sickness. Those were also antihistamines. So, I mean, if those were an antihistamine that treated motion sickness, like the dimenhydrinate and the meclizine, that would be basically, like we could throw this one in there too. And then insomnia, because again, that drowsiness effect helps us. I mean, we saw it with our farm lab. That was one of our skills. So it's given for people who are having difficulty sleeping. And then we could just move on. Alrighty, thank you. So big thing to watch out when it comes to IV or IM Benadryl. This is kind of a weird situation because it can actually cause an allergic reaction, just like every drug. But this is kind of scary because at that point, it's like, then what do you give to somebody that's having something like that? So that's something kind of pretty, you got to be careful about. That's pretty dangerous. So when given by IV or IM, they could have an increased risk of an anaphylactic response. Um, and then when giving IV, this is the only real slide in the chapter that, or the presentation that has a flow rate. So maybe it might be good to remember this: 25 milligrams per minute to reduce the risk of shock. Right? We probably, I don't know if it will come up, but it's the only slide that has some kind of flow rate. That's pretty important, right? I mean, we learned that with Vanco about the 10 to 15. Um, you have to, maybe it might come up. Who knows? And then when administering IM, you inject deep, but I mean, that's kind of, I'd imagine, kind of any drug, really. If you're going to be going IM, you have to go deep anyways. And then it's a category C drug. And I would kind of probably imagine that as like because of the side effects, right? It's not really good, especially the drowsiness, the altered state of mind that could occur, or the excitation, right? Probably not safe for pregnant people. So we would go down, go up. Adverse effects, right? So you can keep going a little bit. Keep going, keep going, keep going. Right there. So the things that I have boxed, just like all the other uh, like slides that we have uploaded in videos, things that are boxed are things we already talked about. So they're just more for review. But anything brand new, basically, is just talking about that whole, the drowsiness effect diminishes with chronic use. That's kind of it. But in the end, this is all just talking about, again, the same thing. Only real thing to notice is that when it comes to Benadryl use with children, instead of having a drowsiness effect to them, they have more of an excitation effect to them. So it's possible. It's not that it'll happen every single time, but it's possible. And I mean, it even says it right here. Excitation is more frequent in children than adults, right? So adults would probably be drowsiness, but with children, it would be excitation. That was really the only real new thing that I wanted to point out. Everything else is kind of just we already went on that, so we could just move on. Contraindications, right? So obviously, we would not give this to somebody who is allergic, like every other drug, right? BPH, and you might want to scroll just a little bit down so people can kind of see a little bit. Right there, right there, right? So you probably wouldn't want to give this to a patient with BPH, right? Narrow angle glaucoma, because that has a lot to do with high pressure in the eyes, which, what did we say happens? Tachycardia, right? If you get tachycardic, even though it's said that it's possible to have, some patients can have mild hypotension. For the most part, tachycardia is associated with high blood pressure. So, I mean, either ways, it maybe the pressure isn't high, but the heart is pumping hard. That's still adding a lot of pressure to our eyes. I mean, after all, I don't know if you guys have ever lifted something heavy and start feeling pressure immediately in your eyes. That that's kind of like one of the first vessels you start feeling pressure in. So that's probably why you have to be very careful with patients that have narrow angle glaucoma, because that has a lot to do with high pressure in the eyes, and then that tachycardia can make that pressure worse, which can kind of facilitate being blind pretty much forever. So now I want to draw the connection to the BPH and the GI obstruction, right? So in a GI obstruction, we're not really having a lot of motility, a lot of movement, a lot of real full-blown, I guess, no, not exactly digestion, but it's just there's a blockage, right? There's no mobility, there's no motility, there's nothing going on, there's no peristalsis that is helping move a bowel movement out of the colon, right? That's well, I mean, it's not only limited to the colon, but typically that's what could be going on, right? So a GI obstruction, we could kind of look at that as like our body is not really um, it's not really turned on, right? Like it's too relaxed, right? And then BPH is a drug that happens to, or not a drug, sorry, it's a condition where your prostate is just enlarging a lot, right? So that is causing urinary retention, right? It's urinary retention related to a complication with BPH. So we said with the parasympathetic nervous system, that allows us to have resting and digesting. Our body's not panicking, it's not going. So it allows us to urinate, right? It lets us go ahead, urinate and all, and then it also lets us have digestion and move things and have peristalsis. But this type of drug, right, the Benadryl, actually causes that anticholinergic effect that we talked about. And then that effect, what did we say? It basically halts any type of cholinergic activity that we were talking about, right? So if the patient can't urinate already with BPH and you give them a drug that basically makes you have urinary retention because now you're not voiding, that would probably make the BPH worse. If the patient isn't really having a lot of motility in the GI tract because there's some kind of blockage, and you give them a drug that again has an anticholinergic effect that basically slows down digestion because you're in fight or flight, right? That's probably going to make it worse. Now going into interactions, right, with drugs. So with use of other central nervous system depressants, right, they cause more sedation. Wow, what a surprise! Sometimes some drugs act in synergy. One thing that is very interesting, right, and then CNS depressants you can always kind of associate with things like sedation, right? There they are, sedation, especially with opioids or alcohols. Anything that lowers your body, suppresses it, will cause increased sedation. So that's mainly the big one to watch out for. But one of the big things, right? These MAOIs, these are special antidepressants, but they have a lot to do with causing kind of like they typically have a lot of problems with interactions with types of drugs that can cause a lot of things with the central nervous system. These happen to cause a hypertensive crisis with with the Benadryl, right? A lot of these MOIs, I mean, I don't know if you guys have caught on. They come up a lot in our med cards. They have a lot of problems with them. This one just happens to be one of those that causes a hypertensive crisis along with it. And it makes sense because, look, this one's stimulating the central nervous system. This is supposed to be helping out with depression. So you kind of put two things together, and they already have something to do with like having your pressure already up. This can make it worse. So whenever you see MAOIs, kind of associate that with like usually a lot of hypertension, and then you don't want to give something that can cause, I mean, again, even though it says mild hypotension in some patients, typically the tachycardia can lead to a little bit of hypertension, just a little bit, but not too much. In the end, it's just the synergy is not going to help. And then we could go ahead and move on. So for terms of lab tests, I mean, it alters your skin allergy tests. I guess one way to look at it is like, right, you're mainly using this for allergies, right? If you give something that's going to hold your allergies away, might reduce your ability to produce a proper result, right? Like false negatives. Things like Hibane may cause increased anticholinergic effects, right? So again, anticholinergic effects, less secretions, no voiding, no nothing, no real anything producing that makes anything like moist. Basically turns it off, right? And then overdose, funny enough, can cause depression or can cause excitation. One or the other. That's the weird thing. Again, it varies on patient to patient. And then we can move on, and I think that's the last slide, right? Okay, so now we're going to get into intranasal corticosteroids, right? Um, Again, this is still part of the prophylaxis drugs, right? They typically must be administered 2 to 3 weeks prior to allergen exposure, right? So if a person has seasonal allergies and the season's coming up that they know they have allergies, it is probably good to take that like almost a month in advance, right? To really get that, because in the end, these are corticosteroids, right? And they're gonna help us lower the immune system. They're gonna help us shut it down. But these are not PO meds, right? After all, they're a localized drug only related to the nose, right? So they're not going to be like doing a crazy effect off of the get-go. They need to take some time to do the proper effect, right? It's actually the drug of choice now when it comes to treating allergic rhinitis, and you see, again, it's just pointing back to the whole. It needs to be administered 2 to 3 weeks prior to the exposure. Um, the nice thing is that they have a wide range of effectiveness and safety. Funny enough, like we always think, oh, corticosteroids is probably going to cause so many different problems. It's going to do this and that. Funny enough, intranasal corticosteroids don't actually really have that many side effects other than local side effects. And even then, those local side effects are going to be kind of mild than what like you're really getting for. So that's pretty. It's a pretty neat like a helpful drug. And I highlighted in green the mechanism of action, really, right? So it decreases secretion of inflammatory mediators, right? Because it's a corticosteroid. It turns off the immune system, but only really here. The intranasal corticosteroids, it says it's in the name. It's only really doing the nose, right? It's reducing edema, right? The edema we can associate with the buildup of fluid, the congestion, the all those problems that are occurring, right? And then it causes mild vasoconstriction. What did we say is attached to that the sympathetic response, right? Vasoconstriction. And then what did we say below right here? Anticholinergic effects. Again, it's not that they're direct, but they're tethered. So if this has vasoconstriction, you could kind of start expecting, especially when we went over like the big diagram with the nose, right? Big blood vessels, big dilated blood vessels allow for mucus production. But if you constrict them, they limit the production, right? And that's what you want because you want to basically get rid of the congestion and the histamine response. So this is, again, long story short, just helping out with anything relating to the immune system, turning it off basically, or like safely turning it off, reducing edema, which is going to go hand in hand because edema is associated with immune response. And then the vasoconstriction helps dry things out, which is what we want, right? We want to get rid of the congestion. Um, so the prototype drug, right, is fluticasone, right? And that's Flonase, right? The nice thing, like all corticosteroids, they end with zone at the end. But we do need to watch out with the Flonase, right? So kind of careful with that one. Um, the intranasal cromulin. Now we could kind of go a little bit into mast cell stabilizers. So what mast cell stabilizers is that they do kind of the same thing. In the end, they do the same outcome, right? They're basically turning off your immune system and preventing histamines from being released, which cause the edema, the mucus production, the allergic rhinitis, all of that. It's just touching on a different cell, right? The corticosteroids is a generalized thing all over your nose. But the mast cell stabilizers specifically target mast cells, which those mast cells, they make histamine. They work with other immune cells to make histamine. So if you turn those off, you're going to have generally the same side effect. I'm sorry, the same intended effect. It's just, again, targeting a different thing. Again, they're going to do the same thing. They're going to decrease any inflammation, right? They're going to reduce edema, and they could cause a little bit of vasoconstriction, which again will help with it. So they're all causing the same thing. It's just a different cell that's being used. Um, Side effects in terms of intranasal corticosteroids, right? So we talked about vasoconstriction, right? We talked about reducing edema and inflammatory mediators, right? So no secretion is going to occur. What could happen if no secretions or I guess like lubrication occurs in your nose? it's gonna bleed because it dries out. So your nose is gonna get dry. You're gonna have bleeding coming from your nose, right? And then you are going to have a little bit of delayed wound healing because delayed wound healing is a common characteristic of corticosteroids in general, right? So it could be that there's like a little bit of a delayed bleeding, or like proper healing, or like it might just bleed easy. That's kind of it. Other than that, there's not really other big giant side effects. I'd imagine the side effects probably just remove the delayed wound healing for the mast cell stabilizers, and they're going to cause the same thing: dry nose and just bleeding. Again, when it comes to this, the professor did say to be more mindful of very extreme side effects. These are not extreme. They're not really a big cause of concern. So, in the end, big giant summary: intranasal corticosteroids are just shutting off our immune system. Obviously, they're going to take a minute because they're not PO drugs. They're going to be turning these things off, and then they're just really going to cause these little tiny side effects that are like almost easy to neglect over. And then if that doesn't work, you can use a mast cell stabilizer because in the end it's going to do the exact same thing. They still need to be used 2 to 3 weeks prior. Um, Even the Benadryl needs to be used 2 to 3 weeks prior because they're not going to have a rapid effect, right? Because it's prophylaxis. Usually prophylaxis takes longer. So same effect. They need to be used every day. They need to be used for weeks to get the intended effect. And that's it, really. There's not much else to go about. So we can go ahead and move up. I added little explanations. You could keep going. I just added explanations to why is that occurring. So now we could go into intranasal and oral sympathomimetics. So these are our relief drugs, right? These are the ones that are going to give you immediate relief. They're fast acting, but just as fast as they work, they also go away, right? So the biggest one to know about, and mainly it's the intranasal ones, right? That one is going to be our oxymetazoline. We have a grid that we made. We put some pictures in there, and we used an ox that has big nostrils and has a lot of mucus coming out of it, right? So the ox needs to take Afrin because oxymetazoline, the brand name for it, is Afrin. Again, it alleviates nasal congestion like that. And it's associated with allergic rhinitis and, oh my gosh, look at that, the common cold. So not only are these for allergic rhinitis, but they're also for the cold, right? Because we've been seeing the cold keep coming back up every single time, right? So that's their two intended effects, right? So the ox has big nostrils. It's having a lot of mucus, so it needs some Afrin, right? It needs to spray some Afrin, that intranasal Afrin, right? For the most part, intranasal preparations, right? They're not really supposed to be used long term. A lot of patients will abuse them, but they're not really supposed to be used long term because if used more than 3 to 5 days, they cause a rebound congestion effect, right? That's kind of interesting because, I mean, after all, it's like, look at it this way, right? You turned off the secretions from the nose, right? You're not making any mucus, right? But your body has been doing that because that's what it thinks is right. Like it's supposed to be making mucus. So the minute you remove whatever thing was holding that mucus back, it's going to be thinking, okay, now's our chance. We're going to now make a bunch of mucus. That's where that rebound congestion comes in. Because the moment it goes away, the drug, then at that point your body's going to be like, all right, let's back up production. And if anything, we're really late. We're backed up on it, so we need to make even more. Right? So they have action in minutes, but again, they typically do not have a lot of crazy systemic effects. One of the most important things to know is that when a drug is given locally, like only in the lungs, only in the nose, they're not really going to have crazy side effects. But the minute you actually take them as a pill, just like we saw with Benadryl, right? Benadryl was a pill. And the minute you take it through the GI tract, that's when you start having more crazier side effects, right? We saw that Benadryl had all those central nervous system altering side effects. So that's something to be mindful about, right? In comparison to these other drugs that are more local, so they don't cause a lot of problems. Um, and then I just added some additional information. So one thing to watch out for, pseudoephedrine, right? That is a drug that is typically, do you mind just bringing up the slide a little bit? Pseudoephedrine is, or bring it up, sorry. Yeah. So pseudoephedrine, right? we're looking at right here. Pseudoephedrine is actually kind of like it's a strong decongestion, right? It's a pretty good decongestion that's commonly used in over-the-counter flu and cough, or I'm sorry, flu and cold medicines, right? So the only thing to watch out for, I believe there's a pseudoephedrine for the nose and they're uh, decongestion, but I also think there's a PO drug. Yeah, this is a PO drug for the most part. That pseudoephedrine is the main ingredient for meth. So this drug is not really used anymore. Well, I mean it is. It's still over the counter, but now when you go over the counter, you have to register. Well, like you have to show your ID and stuff like that. So that's kind of something to just bring up. Like it's legal to get. It's not a dangerous drug. It's just the drug itself is the pseudoephedrine itself is used to make meth. So that's why it's a little bit more controlled now, right? Um, Either ways, same action, right? Intranasal drugs, right? This is one thing. We're going to draw a line in the sand, and we're going to say pseudoephedrine is actually going to be talking about this next slide. So we can go ahead and kind of bring it up a little bit, right? Keep going, right there, right there, right there. So let's put pseudoephedrine in here. Let's just kind of put that in our head, right? This belongs in here because these oral preparations, decongestants, right? Obviously, they're not going to be very effective at relieving severe decongestion. You want to know why? Because they lack that potential effect. I mean, they lack that local effect, right? So it's less potent. It has to go through the GI tract. It has to go through the liver. It has to go through the stomach. It has to go through a lot of things to get to the nose, right? In comparison to the nasal, the intranasal route, that's already right there and taking effect in minutes. This one's not as effective because it takes a little bit of time, right? It's combined with the antihistamines, right? Because what did we say? Right, the allergic rhinitis is caused by a histamine response. You need to take care of the reason, which is the histamine response, and you need to take care of the patient's, discomfort, which is a congestion. So that's why they're usually combined, right? And then there's that oxymetazoline again, and then typically these oral drugs, which is okay, so this is the weird part, right? So there's oxymetazoline. When we looked it up, for the most part, this is more of a spray drug. I'm not really sure why it's here. I tried to look up if there's any Afrin like in pill form. I couldn't really find any like very clear explanations to that. So I feel like this was referring to the slide up here, and the pseudoephedrine may have been the one that was going to be right here because pseudoephedrine does have a pill form. So that part's a little odd, right? But in the end, right, where we could just kind of overlook that because we have that over here. Just kind of think this one's probably referring to that one over there. But what did we say, right? The moment a drug goes through the GI tract, through the systemic digestive system, they're going to have more side effects. And in the end, it's like stimulation of the central nervous system for anti-cholinergic effects, right? So we could probably look at again, maybe a little bit of tachycardia, maybe a little bit of like palpitations, not palpitations, but just like a little bit of like higher pressure, things like that. That are side effects to oral preparations because again, these are drugs that are not going to cause crazy side effects. They're just more like maybe GI upset or stuff like that. It's negligible kind of side effects. It's not going to be like you take it and your arm's going to like shrink and fall off or something. But that's generally it. Again, to just summarize, intranasal decongestants mainly are going to be the oxymetazoline. Ignore this. That's going to be for the nose. Works in minutes. Doesn't really have a lot of side effects for the most part, but it does have the rebound effect after chronic use, especially after 5 days of use. Um, that's generally it. And then the PO drugs, they don't work as fast. They're still strong, but they just don't work as fast. Um, and then they're usually combined with antihistamine products because usually that's what's going on. It's just stimulation of the central nervous system. That's it. There's not much else to go about. So this just goes into another slide that's just review really. It's just talking about what decongestants are. Funny enough, they treat congestion. Wow. Adverse effect, there's that rebound effect that we talked about. More stinging and dryness in nasal mucosa because of the anticholinergic effect. Again, now that we've established our knowledge about sympathetic nervous system and anticholinergic and parasympathetic and cholinergic, this stuff becomes secondhand almost. Why? Like it happens and then now you just know what's occurring. So we could just move on, right? Cough. We're almost finished. So cough, right? Usually there are a couple different things that can help with the cough, right? So a cough is it could be a dry cough, right? Like no mucus, or it could be a productive cough, like with mucus, right? So typically, if your patient is just coughing like crazy with no real mucus production, you would give an antitussive, right? But if you have a patient that has a situation where, like a patient with cystic fibrosis or like things with about COPD, right? Anything that's producing a thick mucus, like in emphysema and bronchitis and um, all those kind of situations, right? Cystic fibrosis, maybe pneumonia, all those mucus things. You don't really want to remove the cough reflex because if you were to remove it, they run the risk of aspiration because you basically turned off their because the cough is like kind of like a survival thing, right? Like what happens when you accidentally drink water and it goes the wrong way? Like you start coughing like crazy because you're not supposed to have any foreign substances in your lungs for the most part, right? So that's the reason why you don't really want to get rid of the cough reflex for patients like that. But if your patient is just someone who's generally healthy and they're just having a crazy cough, you probably want to give them the antitussive, right? The biggest thing to know is that antitussives can be made out of opioids, and typically those were the ones that had codeine in the as an ingredient. So those are pretty strong. Those are really strong. But now those are more reserved to older patients, right? Because they cough so hard, they can hurt themselves. In comparison to a younger person who's pretty healthy, pretty strong, you want to give them a non-opioid one. And that's when we're going to be talking about like things like dextromethorphan, which is Robitussin. Um, so for the patients who have the heavy buildup of mucus, right, you would give them an expirant, which to just give a little teaser, expirants just happen to thin out the mucus, so they make it more, they dilute it, so it makes it thinner instead of thick. It makes it lowers the viscosity. And then you give mucolytics because mucolytics actually break down the mucus. In the end, these two little colors right here that kind of look like the Scooby-Doo colors, come to think of it. Um, these help out with coughing things out. It helps coughing out the mucus that you want to get rid of, right? Because that mucus can cause a pneumonia, it can cause some kind of bad thing, it can cause aspiration, aspiration pneumonia. So these help with that, while these inhibit the cough. So again, you have to be careful how you approach it because the last thing you want to do is give a antitussive to a patient with cystic fibrosis and now they just aspirated something and now they're going to get pneumonia and it's over. So yeah, so we can now move on to the next one. Right. So here we have just antitussives that are non-opioid. The most important one to really full on know is dextromethorphan, right? This one is the Robitussin, the Delsyn, right? There is also benzonatate, but Tessalon, but this one's the one that really shows up a lot, right? For the most part, a lot of these drugs, what are we really noticing as a common side effect? It's like a common side effect that's constantly going on. Usually, look at that. It's drowsiness, CNS depression. There's that paradoxical excitation again. Patients, like, for some reason, getting excited, even though they're supposed to be lowered, right? Common side effects. I feel like these are just, they're very generic in terms of these types of drugs. They all typically cause some kind of CNS depression, right? And we'll actually kind of go into it. Why is it that dextromethorphan causes these issues? It's because it's altering the central nervous system in a way. But for the most part, kind of just look at these. There's a benzonatate, which maybe just glance at it a couple times, but for sure you have to know dextromethorphan because that's the Robitussin. and just know that it just gets rid of your cough. And there's these things, but we'll get into that later. So we can move on to the next slide, right? So here are our expirants, right? They thin out the mucus. I even put the little explanation right there. So the expirant, they thin out the mucus. If you've ever seen a very viscous substance, it like looks really slimy. It's very thick. It's a problem to get rid of, right? So if you were to dilute it, that makes it easier to remove, and that's it. And then there's guaifenesin, which is Mucinex, right? So an expirant, just try to remember the guaifenesin part or the Mucinex, and then we came up with like a little connection to that, right? Guaifenesin, we're trying to say ghost, like a Ghostbusters ghost, right? And the Mucinex, we used a picture of Slimer from the Ghostbusters, so because he looks kind of like the Mucinex booger in a way. And that way we kind of remember guaifenesin. I mean, I know it's not really ghost like word for word, but it helps us remember, especially with the picture. It really pointed out better. I think everyone knows Mucinex, but they don't really know the generic names. So that part, I mean, I didn't know either. So we could just keep going, right? Okay, so mucolytics, right? So there's two different things to know about this, right? So the most important drug to know about is acetylcysteine, right? This drug has two different purposes other than being another purpose other than being a mucolytic. It actually can help you out with the specific brand for an acetaminophen overdose is called Acidote. It wasn't mentioned in here. Oh, here it is. Acetamo-D treatment. I'll write down Acidote below it before I upload it. And then it also helps with this one called Setlit, Seti, how do you say it? Setleave? Cetaleave? Yeah, Cetaleave helps out in protecting the kidney when IV contrast is given, right? So what the professor said was if a patient is being given an inhalation route, which is usually given by a respiratory therapist because it's like a broncho, well, it's a inhalation treatment, right? So they need to be given like oxygen and stuff like that. Usually that means that they're being given this drug specifically for mucus. If it's being inhalation, right? Because kind of think about it in a like think outside the box, right? It's inhalation. Where is it only really going to go? The lungs, right? It's mainly going to go around here, mainly in the airway and stuff. So if you take that inhalation, it'll break down the mucus. But if you're giving it as a pill, why would they be taking it as a pill to break down mucus? That would take way too long. Because this drug works pretty good. Um, it just has some funny side effects. But the PO one, that one is just more for protection, right? So if you see cetyl leave, kind of picture like it leaves out IV contrast from the kidneys, right? It leaves it out. And then you see acidote, that means you're giving the antidote for too much acetaminophen. Um, for the inhalation route, usually the most common side effects are the unpleasant odor because it smells like rotten eggs. It can cause nausea, right? Like, I mean, after all, you smell something really bad, nausea, and then it causes severe nausea, which is just, I don't know, nausea squared. And then vomiting, because what happens when you get super nauseous? You vomit, right? And it causes a bronchospasm. I guess you could kind of look at the bronchospasm as like you smelled something so bad, you start coughing. Maybe you could look at it that way, like, oh my gosh, like you kind of start having like issues breathing and stuff. Like, have you ever smelled something so terrible it kind of takes your breath away? Kind of like that. There's also Dornase alpha, which is another inhalation treatment. Pneumo, which is Plumozyme. So maybe just kind of glance over them, but I feel like the most important one would probably be the acetylcysteine for the majority. And then we could just move on, right? So here's the antitussives, right? We're just talking a little bit about them, right? Dextromethorphan, Delsim, Robitussin. In the end, the mechanism of action that it's doing is that it's just raising up the threshold in the medulla because the medulla is in charge of a lot of our basal survival like functions. It's just raising the threshold for the cough reflex. That's all it's doing. The opioid ones do a very good job at that, but this safer alternative also does that pretty good. Works fairly quickly. It works, I think, in like 30 minutes. And I'll actually talk about it in a little bit. But for the most part, the adverse effects are very negligible. Dizziness, drowsiness, I mean, we already talked about that. It causes things with your CNS system, right? It like lowers it. But don't forget that it can also cause excitation as well. But GI upset, I don't even think we really need to look into that because that's that's every drug. Um, thank you. The nice thing about dextromethorphan, right? You could bring it up and stuff. It's all right. Is that it has many different routes of administration. Tablets, liquid-filled capsules, lozenges, liquids. It has many different. So it's a very universal drug, right? Oh, and then look, there it is. The 15 to 30 minutes. It works pretty quickly. Um, and then there it is. Just acts on medulla, but it lacks any of the analgesic or euphoric effects like the opioid ones do, right? So that's it. And it doesn't cause dependence because it's not really an opioid. And then we could just keep going. The biggest one that only really mentioned there was just if the cough doesn't go away with the use of it, you should contact your provider. But it's like it's kind of obvious because hey, this didn't work. You should probably call your doctor. Category C, right? I'm noticing a very common reoccurrence that this is category C, right? And then we said there was another drug, the Benadryl was also category C. It's not really a good given drug for them too. So seems like these drugs typically are not really something that pregnancy should use typically. Um, and then one thing to watch out is avoiding pulmonary irritants, which kind of makes sense. Would you really want any patient to be around pulmonary irritants? Not really. But it does lower the effectiveness of the antitussive, which makes sense, right? Usually irritants make you want to cough. So if you give more of the coughing stimuli to a patient that's trying to get rid of it, probably it's going to make it worse. It's kind of it, really. And then we could just move on, right? I boxed in things that, again, we already saw, so we can ignore that. But this is just examples of what the central nervous system toxicity can be. Slurred speech, ataxia, hyperexcitability, stupor, respiratory depression, seizures, coma, and psychosis. So all this stuff is related to a freaking anti-coughing medicine, which is hilarious. But what did we say several times before? If we're messing with the central nervous system, especially the brain, you're going to have pretty big possible adverse effects because anytime neural tissue is so sensitive, any little alteration can cause a problem. Um, Again, like there's that whole thing, don't have oxygen for 6 minutes and you start having brain tissue death. So any little drug that can kind of mess with it will cause big problems. So if there's CNS toxicity, these are just some examples that you can use if you see it on the test. It's like, oh, slurred speech, that's an alteration in the CNS. Psychosis, that's another thing that happens. Seizures, they're not supposed to be having seizures. Respiratory depression, that's the respiratory, CNS depression, stupor, ataxia, all those things. Um, Big thing that it's here's that repeat. It's contraindicated for patients who are having excessive bronchial secretions, especially from like complications of asthma and emphysema. Again, you want them to cough things out. And another thing to watch out: this is not meant to be used for a child that is 6 years or younger. I guess in the picture, going back to dextromethorphan, right? We can look at it as we made this kid, right? Dexter, right? And he's like 6 years old. And perhaps like he should not be like he's coughing a lot, but like he's going to be given Robitussin for it. So we're going to have the picture. Think Dexter, he's coughing. His mom is giving him some Robitussin, which is just the same. It's just a brand name of it, and we're making sure that he's 6 or older. And then maybe the kid looks a little mad or something just because of like the psychosis or like he looks sleepy and stuff like that. Yeah, we'll just say he's sleepy. That makes it easier. I don't think a lot of people get psychosis from a freaking anti-coughing medicine. I hope not, at least. But we could just go up now. Drug-drug interactions, right? So in this one, it can actually cause excitation, right, with MOIs, right? So MOIs, again, there's that antidepressives. but it can cause excitation. And let's focus first on excitation and hyperprexia. What hyperprexia is a very high fever. So there's hypotension right there, but we said with MAOIs, it causes a hypertensive crisis with Benadryl, right? Obviously, it's for a bit of a different purpose, but we can now think of if it causes a high fever, your blood vessels might need to dilate in order, because like what happens when someone's really hot? They get really red, right? Because their vessels dilate, because the vessels want to be as close to the surface as possible so that when sweat comes in and air passes by and cools you off, that kind of like transfers over and it cools you down, right? So what happens when your blood vessels dilate like crazy? Hypotension, right? So that's the way I'm going to approach this, and I hope it helps other people too. Grapefruit juice, what did we notice? I mean, a lot of times, whenever grapefruit juice is used with a lot of patients, it causes toxicity of whatever drug they're taking. So, grapefruit juice seems to like kind of hold off the like the liver, right? The liver is supposed to process all these drugs, so it kind of occupies the liver, and then now this drug just stays in the serum for longer times, and that's where you get the toxicity, especially if the patient continues to take the medicine. And that's generally it. We could just move on. And then we are at our last slide, right? So expirants and mucolytics. So I highlighted here in yellow. It's a little hard to tell, but this is yellow. This is kind of like, I'm going to call it Scooby-Doo green because I just keep thinking of the van. Um, the yellow is supposed to just have the that's what these two things do, right? That's like the common trait. Okay? Um, but in the end, well, actually, no, I realized I kind of didn't highlight that well, but in the end, I can re-highlight it once I upload in the thing. So I'll just point to which one does what. Mucolytics does this. They break down the mucus, right? Expirants just make things thinner to make it easier to remove. I'll update it once I upload to the Google Drive. So guaifenesin, right? What did we say that drug is? That is Ghost Mucinex. Yeah, we're gonna think of the booger. Acetylcysteine, right? What did we say is the oh, we actually never said the brand name of acetylcysteine, but it is no, that the inhalation one. The inhalation acetylcysteine, Mucomist. So we could kind of just think it's going to be an inhalation treatment, right? It's going to be a nebulizer treatment. There's like that the little fumes going through you. It looks like a mist, right? Like a fog. Mucomist. Mucomist for this one. But the PO version is Cetaleave, leaves contrast out of kidney, and then there's Acidote, the antidote for acetaminophen overdose. And then in the end, here's just a reminder: cystic fibrosis, chronic bronchitis, and thick mucus production are the indications for these drugs. And that's it. I'll update this, and then we'll turn it up when we finish to the Google Drive, and then we can pause because we're done. Alrighty, so we're going to go ahead and continue and get into chapter 40, right? So mainly going to be for asthma and a little bit of the COPD stuff, but mainly just asthma, right? So lower respiratory tract, it's semi-permeable, right? It's the collarbone and below, right? Semi-permeable, and what it's referring to is just the alveoli that we use. That's where diffusion occurs, while specifically like external respiration where like air is, oxygen is exchanged for CO2. That's pretty much it. And the semi-permeable is what allows the CO2 from the blood vessel to cross over and then get O2 from I don't know, the air pocket, and then go into blood and exchange constantly to allow for proper uh, respiration or diffusion. So now we could go, oh, I'm sorry. Yeah, it's just external respiration. So yeah, we could just go up and just move on, right? So respiration, two different ways of approaching it, right? It's just talking about how O2 is coming in. We already went through that. Ventilation is air going in and out of the lungs, right? So think of ventilation. I don't know. For me, that's kind of just stuck in my head now. Just ventilation, air coming in, going out of the lungs. But perfusion is, the blood is flow of blood through the lungs, which is, you could say that about any tissue in the body, really. External respiration is exchange of O2 for CO2 in the lungs, like specifically outside. Internal respirations is in the tissues, right? So it's all referring to those things, right? Like in the muscles and all that stuff. That's what it's really talking about. And then it's just, referring back to the autonomic control of airways with the bronchioles, the sympathetic branch, and parasympathetic branch, right? So what did we have all the way earlier in the beginning of this video, right? We had, I'm sorry, the sympathetic nervous system, and we had parasympathetic nervous system over here, right? So look at that. Look, dilation. What did we have on sympathetic nervous system? Bronchodilation. Constriction. What did we have on parasympathetic nervous system? Constriction, right? So there's that pattern. That's why that picture up all the way in the beginning helps us understand what's going on down here. And what I put right here is that a beta 2 agonist is used, right? And that beta 2 agonist is going to be our teaser for albuterol. So later down in the next couple weeks, we will be starting to have things like beta 1, beta 2, alpha 1, alpha 2, like things like that. Right now, let's not get it too complicated, but I want to at least let people know what beta receptors are, right? So right now, all I want you to think of is beta 1, think one heart, because we have one heart, right? Beta 2, think two lungs. We have two lungs, right? Now with beta 1, to give a little teaser, beta 1, if that is stimulated, it makes the heart contract fast, like harder and faster, which makes you have tachycardia. That's why patients who have, like hypertension, heart failure, and chest pain, they could be given drugs that are beta blockers, right? They're preventing, and those are for beta 1, the heart. They're calming the heart down. Beta 2 has to do with bronchodilation specifically, right? So I said beta 1 makes your heart work harder, right? Which side of the nervous system that we talked about might that lean to? So that would lean to the sympathetic nervous system, right? So the beta blockers calm the sympathetic nervous system, but we want a beta 2 agonist to ignite the sympathetic system, right? Because we want bronchodilation. We want to get as much air in our lungs as possible in comparison to parasympathetic that's actually bringing it back to normal and constricting it, which can really cause some big problems. So just to review, just right now, think of beta 2, two lungs. We want to activate it. We want to cause this sympathetic response to dilate. So here I put a couple, like a diagram just of what asthma as a whole will be using, right? There's going to be rescue drugs, and honestly, the most important rescue drug to know is albuterol, because albuterol works the fastest. There are prophylactic drugs, which those drugs just help obviously prevent an asthma attack or lower the frequency or lower the severity of it, right? We have inhaled corticosteroids, which obviously end with zone, right? Like the prednisone, fluticasone, prednisolone, so many zolones. There's so many, like they end with zone, right? There are also anticholinergics, right? Before I move on, inhaled corticosteroids, usually they occur through breathing treatments, mainly because they need to reach the lungs to shut the immune system down a little bit. But anticholinergics are inhalers. So they're like your little inhaler that you shake before you give, right? Like you're just a little inhaler. And typically they end with tropium, right? When we see the anticholinergic word, we basically want to just imagine what's going on right here, right? What was mentioned in the sympathetic. And we're basically turning off all the things that are relating to the lungs in terms of right here. That was in the parasympathetic, right? So edema, inflammation, mucus buildup, and things like that, right? Because you want to prevent that. You also have leukotriene modifiers, which we talked about earlier, that can help out with inhibiting the immune system. Mast cell stabilizers, which again, those help lower the immune system. And then, so leukotriene modifiers, they end with Leukost, right? They're usually a PO drug. Mast cell stabilizers, this is actually the name of it. It's cromolyn, right? And this is usually a nebulizer treatment as well. And then finally, there's methylxanthines, and these end with feline, right? Like a fine line, and we'll feline, fine line again, ph or fy. They end in similar suffix structure, and they're usually PO drugs. And the fine line is going to help us later when we talk about them. So keep these in your head. Watch out with that. Big thing that I want to establish is rescue drugs would be given for an acute um, asthmatic attack, and it would provide relief. Prophylaxis drugs, if given, can reach death because they don't help. They don't help for an emergency. Albuterol is the primary emergency drug. These just keep it at bay. And then also these, again, you have to take them consistently because they're just like the allergic rhinitis drugs. You have to take them consistently because if not, the effect gets lost, and then now you can run the risk of having an asthmatic attack. So we can go ahead and move on. So administration by inhalation, right? It's the fastest route. I mean, it makes sense. It goes right to the lungs. That's like the most important thing. The rich blood supply in our lungs, right? It's super vascular. What is it like? The bronchus looks like a tree, right? The vessels, it looks like a big tree in our chest, right? Um, Obviously, we're giving the drugs right to the bronchioles. That's where the problem is. That's where we want to fix it. Rapid and efficient, and the biggest things to watch out for, right? We talked about this earlier, right? Oral drugs take longer for them to have an onset, but they also last longer. That's referring to you know, these prophylaxis drugs because we saw PO be shown up a couple times in those, right? But we didn't see a lot of these show up in these. There is a PO drug that could be given for an acute asthmatic reaction, but you don't want to really give that one because it does not work as fast as albuterol. Albuterol is the like golden drug if you want to look at it that way. The aerosol therapy, right? And that just it's just a straight transition to this. Aerosol therapy is what that albuterol is, right? It's a breathing treatment. It is the nebulizer treatment. It's faster effect, but it doesn't last as long. So just know there's a yin and yang to this type of stuff. So we can move on to the next slide. Thank you. So aerosol therapy, again, there it is. Disadvantages, right? If you guys have ever seen a breathing treatment be given, like we saw in the slides, we'll see in a little bit. The mask usually has a little port, and there's a lot of mist created through the use of oxygen and medicine. And the mist is actually the little hole in the mask is allowing too much. It could allow a lot of medicine to come out, right? So the disadvantage is you don't really know how much they took of the med. 10 to 15 could be given because only 10 to 15 could probably use because again, they're only really taking so much because it's exiting out of the port. And then instruction might be complicated. Sometimes it's some patients unfortunately they have a tougher time understanding what's going on, and then they're not getting the full benefit of the drug, right? And then there are um, kind of tougher side effects if the patient were to swallow the medicine, right? So again, we associate there's two gateways, right, or two roads we can look at it, right? The front goes to our lungs, right? The front, the trachea, and then behind the trachea we have the esophagus, right? So if the idea is that it's supposed to go down the trachea and into the bronchioles, you know, so if they were to swallow it, because when we use the word swallow, we were referring to the esophagus, and if it goes into the stomach, like now we can kind of start thinking about it, right? We talked about what beta 1 and beta 2 do, right? So if a patient were to swallow for whatever reason an albuterol treatment, like just the fumes, like they just swallow the fumes and it hits the stomach and the stomach starts processing it, we said beta 1 is to the heart, right? It's going to go to the heart and it's going to cause tachycardia. And if you guys remember, albuterol causes palpitations, tachycardia, nervousness. It causes a lot of things that you see in the sympathetic response. It makes you kind of antsy and stuff. Now that's where we're drawing the connection. Why is that occurring? This is why it's occurring. Because Now, even though it's specifically targeting beta 2, it can still ignite beta 1, right? So that's what this is referring to. We can move on to the next slide, right? This is just the meter dose inhaler. The nice thing about this one is that each puff has a specific amount of med, and if used properly, they get the full dose, and you know how much they use, right? Because they're not they don't have the port of the whole nebulizer treatment. Big things to watch out: shake prior to giving. Another thing too is have the patient, take the puff and take a big deep breath, right? Like a big giant deep breath and hold for a couple seconds and then slowly exhale, just like we did in Farm Lab, right? We shake before we give, right? We instruct them, hey, this is how it's going to happen. You're going to go ahead and, with the, what do you call it, the bridge or whatever the heck you call it, the little spacer. Yeah, you have it there. Have the patient breathe in and out like normal, right? And then that's when you spray. They take the deep breath in, hold it for 5 seconds, then easy breathe out because that gives them the full effect, right? And then obviously you want to rinse out their mouth because again, that's a whole beta agonist in their mouth. Where in our mouth has a lot of blood vessels, like the cheek. Well, the most blood vessels would be under the tongue. The next would probably be the cheeks. So if you have like med in there, now you might get that and you're going to get more of an adverse effect. So you don't want to cause that. That's where this is coming in. And then we can just keep moving. Right, so there's that treatment that we were talking about. There's the port, right? Usually like you'll see fumes coming out of that. And this is where the med's coming in and oxygen helps it there. There's not really a lot that could be said about this one. I can't really think of a lot of stuff. It's just put the mask on. Usually it's going to be at a rate of 10 to 15 because it's a nebulizer mask now. That's kind of it. And then this one is kind of crazier, dry powder inhaler. I mean, I guess the med goes into the like the little discus, and then it crushes it, and then the patient just takes like a big deep inhale, and like it like coats the respiratory tract with the med. That sounds kind of uncomfortable. I'm not too sure because ideally it's supposed to be going into the lungs, right? I would imagine that's what's going on. Like obviously it's still oral hygiene because it's gonna get caught anywhere, and like you probably can swallow it, like because right we have our airways, right? We have our mouth, right? So here's our mouth, and then one way, this right here is to the lungs, right? This side is lungs. This side is esophagus. This is esophagus. So when you take it in, depending if the epiglottis is really working well, maybe it goes only here, but it could also possibly go this side too, and that's where you get those systemic effects probably. As I'm more talking about the pill form. Albuterol is a pill? Oh, okay. No, I've only really seen it as a nebulizer, but okay, cool. Didn't know that. That's pretty interesting. But yeah, I guess albuterol is also but in the end, dry powder inhaler, that's what's really going on. That's long story short. So they take it in. It just sounds uncomfortable because you know how it's not really supposed to be dry. Like have you? Yeah, yeah, yeah. It could. That's why. It's like it depends how well the epiglottis held it off. But it sounds like it irritates. Yeah, or maybe the medicine is tailored to not irritate. Could be that. Yeah. I mean, for goodness sakes, you inhale a little bit of cinnamon and you're damn near choking. Yeah, so it's like that kind of sounds like this. So, yeah. But we could go ahead and move on. Right. So now we're going to be talking mainly about we'll finish with the rescue drug, but the most kind of big things to really that are more unknown are the prophylaxis drugs, right? So we have talked a lot about corticosteroids, right? We've talked about intranasal corticosteroids, which because it's only intranasal, right? Like a spray, it's only going to be localized in your nose. So it's not going to help when the problem is down here. Would an intranasal corticosteroid help? No one, because it's not going to get there. That's the reason why this is an inhaled corticosteroid, because the idea is, again, you're taking in the treatment, right? And it's to your lungs and it's staying in there for a good amount of time, and that's where you get the intended effect, right? So inhaled, these are the drugs of choice for long-term prophylaxis. Makes sense. Again, because it is only localized to the lungs, for the most part, side effects are not the craziest, which is really nice. I mean, if anything, the only crazy side effect is the oropharyngeal candidiasis, right? And why would that be, right? Because as you're taking the drug, where is it going through before it gets to your lungs? It gets through your mouth first. So if you and then what did we say corticosteroids do? They weaken the immune system. So if they weaken the immune system, you're leaving this just wide open to allowing a opportunistic pathogen like candidiasis to create an infection. That's why rinsing out your mouth is very important. Um, so there are oral drugs that could be given for short-term therapy of severe acute asthma, right? That's where I put it, and I kind of glanced over it all the way at the top when we talked about rescue drugs, right? So here's a weird thing, right? There's a super teeter-totter way when it comes to treating a severe asthma with a pill, right? Oral drugs, it's a pill. What's going to be faster? Albuterol, that's going to take the medicine directly to the lungs and open the airway that we're supposed to be having open, but it's constricted either because too much mucus or it's actually constricting, or a pill that you have to take, let it sit in your stomach, go through the liver, go through everything, finally to get to your lungs and shut off your immune system. That is, it's still not fully accounting for the mechanical constriction occurring in the bronchus, because obviously the corticosteroids will lower mucus production, they will lower inflammation, edema, they will lower all of those things. But the problem is that will they work faster than albuterol? Probably not. So it is a choice. It's a option, but the the go-to, right? The go-to we establish is albuterol. That's the one that's really important. But chances are it could be that, like, maybe we could be in a scenario where the patient had severe asthma, right? They were taken into the ER. They gave him the albuterol treatment. That's over. Now they can give these oral drugs to help lower it down. Once that happens, then they can go to um, inhaled corticosteroids. So the idea with this, right, is this. Let's look at it this way. It's kind of weird how it's like inhaled. Why is it that it has to be inhaled? Again, you want it to be localized. You don't want it to be systemic. The oral drug is not some, I would imagine, it's not some crazy, like, specific to asthma corticosteroid. It's just probably our regular corticosteroids, like those hydrocortisones that we learned of from a long time ago. Because in the end, it's oral, right? It's shutting down our immune system. Like we learned, it's given for patients with um, what do you call it? Those transplant surgeries, patients with autoimmune disorders, things like that. You're shutting it down for the time being. Obviously, you don't want to be on the oral corticosteroids for long. You want to be on the inhaled ones because those are going to allow you to just have localized side effects instead of, and even then, those don't cause a lot of side effects in comparison to the oral ones. That's the reason why there's a certain teeter-totter way when it comes to approaching these. So ideally, when it comes to prophylaxis, it's all about inhaled drugs, right? Because it keeps it local. Obviously, it takes time. It's not fast because, again, it's inhaled. It's not a fast-acting drug. It's 1 to 2 weeks to show improvement and 4 to 8 weeks for the full effect, and it must be taken daily, right? Well, again, it goes hand in hand. Would you give this drug knowing this as a rescue drug? They'll be fine in 4 to 8 weeks, but by then they'll be dead. So you don't really want to give something like that. The oral drugs are probably something that's given after the albuterol treatment. Once it's like, all right, let's keep it at bay. Like for some reason, this asthma is super persistent. It warrants this use, but this is not the first go-to. And then we can go on to the next one. Right. So again, anti-inflammatory agents. That's what these corticosteroids are. This is more just a summary. Adverse effect, we already talked about that. Don't need to go. Should not be used to terminate. Again, I'm emphasizing that. That is super important. Also treats allergic rhinitis, right? But these are big with the intranasal corticosteroids. This one is more talking about just, this is more of a summary about both, but we said, what is this? We said this is inhaled corticosteroids. We said this is intranasal corticosteroids. And it just decreases the frequency, just like we saw, right? The intranasal corticosteroids are for prevention of allergic rhinitis, the same way how inhaled corticosteroids are for the prevention of asthma. That's it. We can move on to the next slide. So role of the nurse, right? We can ignore that and ignore this because we already do that all the time. But assess for signs and symptoms of infection, and that's referring to the candidiasis that's going on. That's it. We can move on to the next slide. Another thing too, right? So steroid inhalers, that's a thing that you could watch out with. Not recommended for pregnant or breastfeeding women. That's something in our stuff that we got to watch out for. And I guess that makes sense. You kind of doesn't seem like a good idea to be giving things like that for someone who is undergoing like development for a fetus. And then the primary use, again, it's overemphasizing this preventing distresses. It is not for acute rescue. And then watching out, again, for simple infections. It was already talked about again. So it's just a repeat. But look at that. We said that if it shows up multiple times, chances are it's very important. Again, this is not a rescue drug. And then we can move on to the next slide. Thank you. Leukotriene modifiers, right? So this is now one that's a little bit crazier because again, it has the same intended effect of lowering leukotrienes, right? Well, again, all these drugs are just really the outcome at the end of the day is to lower the immune system's function locally within the lungs in order for you not to have another asthmatic attack, right? Leukotrienes are specific to our lungs and they're found in our brain as well. These drugs are a little crazier because if I recall right, they're a PO drug that happens to be able to cross the blood-brain barrier. These drugs can actually cause a lot of central nervous system psychotic things, which is really bad, but it helps with asthma and it can help with like sports related asthma, like activity related asthma. So that's kind of interesting. We'll dive into that, right? So leukotrienes, right? They're mediators for immune response. They're the same way with like our mast cells that make histamines. Leukotrienes, they facilitate the creation of histamines because again, our leukocytes, they're all these different types of cells, basophils, neutrophils, there's so many macrophages and so on and so forth, lymphocytes, they all bring up the whole histamine, right? So they're always going to be involved with allergic and asthmatic reactions because again, that has a lot to do with these respiratory issues. Allergies up in the nose, asthma down in the lungs, right? Leukotriene modifiers are used as prophylaxis, which we already established a while up there. And look, reduce the inflammatory component of asthma, right? So they have less mucus. The less mucus they have, the better, like you're already removing one piece of the puzzle, right? So like we could just draw like a little circle right here, right? So this, we'll pretend we're looking, yeah, we could see it. We could just pretend we're looking down the windpipe, right? The bronchus, right? So if we have a lot of mucus right here, that's kind of, are we getting the full effect of breathing? No. So if you get rid of the mucus, look at that. Now you have the full effect. Now what if you have mucus and you have inflammation, right? Now you have even less room. So if you use a leukotriene modifier, or the corticosteroids or all these other drugs, they get rid of all this stuff, right? And they allow for this nice, wide open airway that we want, right? The big things with it, right? The prototype drug we're going to go with is montelukast, right? So we have Singulair, that is the trade name, right? And then there's a mechanism of action, prevents edema, which is, buildup of that fluid, and, prevents inflammation and mucus and stuff by blocking leukotriene receptors. Again, the same the same thing as we talked about with allergic rhinitis. Same goal and intended outcome, different cell um, that you're targeting. That's it. Other than that, there it is, prophylaxis. One more time, it's coming up a lot for chronic asthma. Now, here's the thing, headache, nausea, and diarrhea. So these are the common things, but there are some crazy adverse effects. I wouldn't really call these adverse effects in comparison to the crazy ones we're going to see. Um, these are more side effects if you want to look at it, because the adverse effects are they're pretty extreme a little bit. It seems like it. But we could go ahead and move down, right? So now we're gonna talk about MonteClass a little bit more in depth, right? So this was already talked about, so we're gonna ignore it, right? But this is new, the exercise-induced bronchospasms, right? So that means that when would you probably want to take this drug if you know that you're going to have a sport coming up or some kind of meet? You probably want to take it beforehand, right? And then look, there it is. They treat allergic rhinitis like we mentioned earlier. I just would imagine with the possible adverse effects, you might not want to give this for something as simple as seasonal allergies. You probably would want to do it for asthma because asthma is more complicated, but you probably wouldn't want to go that crazy with like allergic rhinitis, right? So it's a PO drug. It does work fast. But what did we say is like the golden rule when it comes to a rescue drug, even though this one works pretty fast, even if it's PO? We said, what is our only rescue drug for asthma? Albuterol, because that's what's really going to help you. So it's not recommended. It is not recommended for termination of an acute bronchospasm like asthma, right? The nice thing is that Montelukast is the only leukotriene modifier that is approved for pediatric use. So if there's a different leukotriene and they all end with Lukast, and the question would probably be like, you have a kid that's like aged 11, right? But it's not Montelukast. I'm imagining that basically means it is not allowed for that child, because Montelukast is the only approved leukotriene modifier for peds use. So if you don't see Montelukast, but you see some other Lukast, that probably isn't for the kid, because that is probably contraindicated because it's the only approved drug. The nice thing, chewable tablets. I mean, it's a kid. Usually they don't really want to take medicine, so they could be given with food. That's a nice thing. Look at that. And there's the ice cream. That's like the first time I've ever seen that get mentioned in these slides, so that's kind of nice to see. But we can move on to the next slide, right? Again, not to use to terminate asthma attacks. If it keeps showing up, that is very important. And then in terms of preventing exercise-induced bronchospasms, you take it 2 hours before the activity. And it's a pregnancy category B. I like to imagine it, right, if it's okay for children in this one, right, Montelukast is approved for children, and it's the only one that is. It's nice to kind of have that connection with the pregnancy category as well. So in this one, we're imagining this kid, right? He's out in a soccer field, and his name is Lucas, right? And he's from El Monte, the reference or whatever. And outside, there's a lot of air, right? Singular. It's super windy, singular. And the kid, he's gonna have a like a meet, like a soccer meet, but he has to take the pill. So we could draw the kid taking the pill 2 hours before the activity, to prevent any asthma. And that's our way to remember, Montelukast. We have Lucas from El Monte. that is out in a windy soccer field and he's taking the medication 2 hours before activity. So we can now move on to the next one. To the next one. No, we're good. So here's where things get very interesting, right? So we said Montelukast, right? They don't really cause a lot of crazy side effects, but headache is the most common issue. Nausea and diarrhea, those are so generic. Those we can say are side effects. But adverse effects, again, because we said leukotrienes are in our lungs and they are in our brain as well, and this can cross the blood-brain barrier. And we said that anytime you alter the central nervous system, you're going to do something to it, which is going to be really weird. And look, so even though it's rare, they can cause this serious, oh my goodness, this marker's dead. They're going to cause serious neuropsychiatric events like suicidal ideation, so you might want to check on them, how they feel, hallucinations, aggressiveness, and depression. So maybe you could draw Lucas as like sad, like really sad, or very mad, one or the other, however you want to look at it. But that's something to watch. That's a pretty extreme side effect. So I would try to remember this because this is big. And then the only contraindication is hypersensitivity, which is pretty nice. Um, oh, I mean, this is more to make the emphasis on this part, this part, and this part. I don't know. This is just something I'm really looking at. It's like, wow, that's kind of crazy about that drug. Yeah, yeah. So if it does like think, oh my goodness, this is probably that one. But like I said, the only contraindication is allergy. But I mean, here's rare cases of hepatic failure, right? They've been reported with patients who are taking it with pre-existing hepatic impairment. We've learned again. That's something we've. Of course, anyone who's having like renal issues or liver issues, you always have to use it with caution with everybody. It seems like if paper touches them, they might explode or something. So we could just kind of overlook that. So we could go on to the next slide, right? Drug-drug interactions. Thankfully, not that many drug-drug interactions, but I mean, that kind of gave us a little teaser about like if it causes renal failure in patients who are already having renal issues, chances are it's probably messing with your liver, so it raises your ALT. That's kind of it, really. And that's it, really, for Singulair, Montelukast, right? So now we really only have to go into therapy with leukotriene modifiers, right? So the biggest thing that we have to watch out with, right? Obviously, you check the respiratory effort, the lung sounds, whatever. This is just part of assessing your patient physically when it comes to respiratory issues. But you do want to watch out for their CBC, right? And I guess we could do that too because again, you want to be monitoring to make sure it's working, right? I mean, after all, their their blood might not be showing like promising things. Is like there's low levels of oxygen because of difficulty breathing. Periodic liver function because of the whole it can cause liver damage, right? Another thing too is this, like many other drugs with warfarin or other anticoagulants, they increase the risk of bleeding. That's it. Like every other drug we have learned, it seems like every drug makes warfarin just work better. Um, this part is what I really want everybody to kind of look at more, right? So phenytonin happens to be a drug that is for seizure medication. We could bring it up. We could bring up the slide all the way up a little bit more, a little bit more, a little more. There you go, right there. So we could say phenytonin, this drug right here. This drug is used as an anti-seizure medication, and actually it's come up a very few amount of times in our other chapters. This drug, right, is supposed to be for seizures, which is all related to our brain. And we said leukotriene modifiers can go into our brain as well. When taken with phenytonin, drugs like montelukast or other leukotriene modifiers can actually make the symptoms of asthma worse because they have like I don't know, they like butt heads, I guess you can say. Like it makes things like it kind of cancels out or it gives some kind of weird effect. But long story short, you have to watch out with patients taking phenytonin, right? This drug right here, theophylline, right? Theophylline. What did we say? Fine line. What was a drug with fine line in it? That's our methyl oxy. How do you say it? I forgot exactly, but it's methyl. Wait, pause it. What is it? Yeah, methylxanthines, right? So that's what this drug is, right? They end with feline or filine or whatever the heck. These are our, I'm going to just draw a little arrow out here. These are our methylxanthines, right? These are very important to know because what leukotriene modifiers are, in the end of the day, is they're an immunosuppressant tailored to the respiratory system, specifically in the lungs, right? Theophylline is like a lot of these other drugs that are methylxanthines. These drugs are very closely resembling to caffeine. What is caffeine usually associated when it comes to the types of nervous systems that we had? We had two nervous systems on this board. They're mainly with the sympathetic, right? Caffeine will make your blood vessels constrict, right? They will make your heart race. What do you think they would do to your bronchus? Would they constrict or would they get bigger? Because we're in sympathetic. What would happen? They would dilate. Because we're in sympathetic. Because caffeine, these drugs closely resemble caffeine. If caffeine puts us in sympathetic nervous system, they're gonna make you have a higher heart rate, right? They cause vasoconstriction, right? Because that's what caffeine does, right? And they're gonna make your bronchus dilate because we're in sympathetic nervous system now, right? So these are used kind of like a combo. The leukotriene modifier is used to lower the immune response that creates the mucus, the edema, the inflammation in asthma. The theophylline or phylline or whatever the heck you call it, that is a bronchodilator. But that one also has its own set of weird side effects. So that's the reason why you should reduce the dosage if you're going to use them as a combination drug, because you don't want to have the strong effect of one messing with the other one, right? Because this one, we're going to talk about it in a little bit, and this one has its own side effects that are kind of crazy. And we already said leukotriene modifiers can cause some kind of crazy side effects, right? So the last thing is you want to put like a crazy powder keg with another one. And I did put a couple explanations, like much more inside that you can zoom in once you look at these slides. Now, with xyleuthon, right? Xyleuthon is an inhibitor of leukotriene production, right? So I would imagine when it says monitor xyleuthon productions, or I'm sorry, monitor xyleuthon levels, that basically means that you probably want to take a look at, like, to draw for example, we said with PPIs, right? PPIs can cause atropic gastritis, right? That's basically meaning we're turning off the stomach. This is turning off the immune system in that way, right? We said that another thing that could occur, right, is cancer with PPIs, right? Because it can cause cancer. And the way I'm looking at it is because if you're shutting down cells that make something normally in the body, like protons that make acid in the context of PPIs, if you turn those off, the body is going to think something is wrong, we have to make more cells. They make more cells, and then again, we talked about this before, right? If you create more cells with no quality assurance, right, because your body's panic thinking, hey, we got to make more cells, that runs the risk of cancer. So to project this onto here, I would imagine that when it comes to xylutton, if your xylutton levels go down, because after all we said xylutton is an inhibitor of the production of leukotrienes, if you get rid of xylutton, right, then that means production is going to keep going, right? That's what's going to occur. So if your levels go down like crazy, it could, I'm not saying it's going to point to cancer, but production is up and that should not really be going on because you want to prevent any crazy conditions from occurring, I would imagine. But long story short, phenytonin with leukotriene modifiers can cause worse symptoms of asthma. When taken with theophylline, those methylxanthines drugs, you probably want to lower the dose because theophylline is a bronchodilator. The leukotriene modifier is a inhibitor of the immune system. And then the xylutton, that is in charge of holding back the production of leukotrienes. So that's generally it. And then look, right at the bottom again, advise patients not to use it for acute asthma attack treatment. Again, I think it's mentioned it like 5 times already, so I think that's like it's really important. All right, so we could now move on. Mast cell stabilizers, right? We talked about mast cell stabilizers in acute, allergic rhinitis. Same thing, except these mast cell stabilizers are now just going to be with, you know, a nebulizer treatment. And again, instead of it being tailored into the nose, it's going to be tailored more in the lungs. But in the end, same thing. We said mast cells release histamine and other chemical mediators for immunity. So if you turn those off, then you don't have that histamine response that you have with all these other drugs that were mentioned. And look, there it is, anti-inflammatory again. You're getting rid of edema, you're getting rid of inflammation and mucus buildup. And it's the same end result as corticosteroids and leukotriene mods. Again, you're just targeting a different cell. That's it. Again, and it's safe. It's very safe. Not really doing a lot of crazy stuff because it's all right here, not all over the body. And we can move on to the next slide. So this, I believe, is the last slide from the slides given to us. They're just things about COPD, right? First and foremost, you would probably give albuterol if they're having a severe COPD, like induced asthmatic attack, right? You would want to give albuterol first and foremost because you want to rescue them. Second, COPD has a lot of mucus buildup production, right? Associated with it, right? We have bronchitis, emphysema, asthma, we have cystic fibrosis, things like that, right? All that mucus, would you give a decongestant? Or I'm sorry. Would you give a antitussive? No, because you want them to cough. So instead you would give them mucolytics or expectorants, right? Because that helps break down the mucus and it helps them cough it out. Oxygen therapy. Again, COPD patients, they happen to be used to having a lower level of oxygen. They're not supposed to have crazy levels of oxygen because if they do, that can actually destroy the respiratory drive. Our body is constantly, our biggest mediator for respiratory drive is our CO2 in our body. Our body wants to always equalize the CO2 we have in our body, in our blood, in our lungs, everywhere in our body, right? Because that's where we contain it. If you were to blow off the CO2 with too much oxygen, this is why these patients need to only be around 88 to 92% because they're having chronic obstructions of oxygen getting to the alveoli, where they could eventually become atelectasis, right? Because emphysema is the final step of COPD. It's the terminal end, right? That they're used to having a lower level of oxygen. And in fact, it's good for them to be right here, because if you give them anything where they're really high level in oxygen, there's a certain spectrum of CO2 to O2 that there has to be. There has to be a fine line of O2 and CO2 balance. The moment one starts taking over for the other, now we're having problems. And in this case, we're talking about O2. You give too much O2, right? So you're providing the patient with too much O2, right? Now we're here. And that's all over here. And this is the little CO2 to the point where we get rid of CO2. We said CO2 acts like a magnet. It acts like a magnet that attracts oxygen to it. If you get rid of the magnet, what will happen to your body? You'll think, okay, I have all the oxygen I need. I could go ahead and stop breathing now because I have everything I need. I'm at 100% oxygen. And if your body, our body's constantly using oxygen from birth to death, right? The moment you turn that respiratory drive off because you blew off the CO2, you can kill someone with this. And it's very important to know why CO2 patients are not meant to have oxygen where their saturation goes really past 92. They are normal at 88 to 92. Obviously, to a healthy person, that is a major alteration. But for someone with COPD, they are not meant to have a high oxygen saturation level via pulse ox, because that can kill them if you overgive them or overdo it if you give them oxygen. Antibiotics will obviously be given for any patient that is having an infection. That's kind of obvious. And then we just have to know that this is the only drug that was really mentioned in the COPD chapter, roflumilast, right? And I would imagine it's like COPD is kind of the last end of it when it comes to getting to death, right? And then there's Daliresp. So I'm imagining if there were to be a question that says like which one of these is a treatment for COPD, these would probably be something that you would click on, or like to like a SATA question or whatever. I would imagine like these are going to be the ones that would show up, right? Obstructed flow again causes chronic bronchitis. It's caused by chronic bronchitis as asthma. And then there's the end stage is emphysema. And obviously you want to relieve symptoms and avoid complications. Again, unfortunately, COPD is like a life sentence at that point. You can't solve it. You can only make the patient comfortable. You can't cure COPD. Because at that point, the damage has been done. Then we can move on, right? So we could zoom out a little bit. We're going to use a little bit of the slides given by the bronchodilator group, and we're going to just scroll down, scroll down, scroll down, scroll down, scroll down, scroll down, scroll down. Keep going, keep going, keep going, keep going. Right there. Okay, right there. So we're going to talk a little bit about asthma. It'll be a little faster because it's not really referring a lot. We're not going to go that crazy about the LABAs, but it's good to know about them, right? So LABAs and SABAs, right? So a short-acting beta agonist, right? In the end, they're all going to be doing the same action, but this one would be for rescue, right? So this one is for rescue. And this one, because it's long acting, would you give it for rescue? No, you wouldn't. So this one is for prophylaxis. That's essentially what it really is. That's kind of it. And the reason why there's a black box warning is not really because the drug kills you. It's because people mistake it, because it still comes from a meter dose inhaler, and they think it's albuterol in the traditional sense of a SABA, right? So it can cause asthma-related death because they give it and it's like, hey, it's not working, let's give more of it. And then it's like, again, they're not having the effect that needs to happen. Again, LABAs take longer to have an effect, but the effects last way longer in comparison to a SABA that is, it works fast, but it goes away fast too. And let's see, there it is again, PRN, not for prophylaxis. So we could think LABA is lava, right? Lava moves very slowly. And then like Saba, can't really think of like something fast with it, but like Saba speed, like speed, Laba. Saba. So kind of look at it that way. We could just move down a little bit, right? So beta adrenic agonists, right? And adrenogenic agonists, right? Salbuterol, again, we're gonna refer back to that first slide we had in the beginning of the video, right? So we said it causes the sympathetic response, right? This is where the indication, well, those, yeah, I mean, it's the indication would be bronchoconstriction, um, but we want dilation, right? So that's what we intend to do. But the indication is asthma first and foremost, right? And in the end, when we initiate the sympathetic nervous system, right, it's it's causing the bronchodilation, but we said sympathetic nervous system is activated, right? So we have palpitations, headaches, this we can associate with sympathetic nervous system, right? Palpitations, right? Your heart's working fast. Restlessness, your heart's working fast. You're in sympathetic nervous system. Your heart's tacky. Again, palpitations. There it is. Insomnia, your sympathetic nervous system. Dry mouth. Why do we have dry mouth? What did we say happens down here that we're preventing from over here from that first slide? Anticholinergic effect. That's where that's coming in, right? And that's it. Oh, and the nervousness, also sympathetic nervous system. And we can move on to the next slide. Right? Okay, so anticholinergics, because it did come up. These end with tropium. That's the big thing. They end with tropium. Atrovent, which is kind of nice because look, atropium, atrovent, it kind of gives you an idea of what the drug is, like from brand to the generic, right? And in the end, it's an anticholinergic in its purest form, right? Anticholinergics are mainly given for bronchitis and emphysema, and it's treating the inflammation part or like the secretions part, so the mucus that is associated with it. But they also help with a little bit of bronchodilation. It could be like kind of pseudo dilation because, again, we have that airway, right, with all the mucus, right? So much mucus. If you get rid of this, right? It's like kind of pseudo dilation, but it can help open up a little bit. But long story short, it is just preventing too much mucus production. That's all it's really doing, because again, it's in the name, anticholinergic, right? So remember, cholinergic, think tropium, atrovent, right? Ipratropium, right? And then it's off-label for asthma, but again, it's not ideal. Overall, it's a meter dose inhaler. Don't take it back to back. Side effects, look, there it is. The hoarseness, drying of the mucosa, because look, it's an anticholinergic. Irritation, anticholinergic. They're not supposed to be dry, but that's it. We can just move on to the next slide. Nothing crazy. Theophylline, last drug for this chapter, basically. So theophylline, right? We said that this is methylxanthine, right? And we said that it is very built similarly like a caffeine, right? So caffeine, again, makes everything kind of get excited, right? Like our sympathetic nervous system is up, right? This is kind of a last resort drug, right? For the most part, right? That's the reason why like patients with like crazy asthma get these drugs, because like if it's really not helping, then this would help. Because it's given for the prophylaxis of asthma, that is unresponsive to beta agonists, specifically those LABAs, right, the longer acting ones for prophylaxis, and inhaled corticosteroids, right? So the biggest thing to know, they cause bronchodilation by increasing C-amps, right? I feel like the most important thing really is to know that they cause bronchoconstriction, but even more important to know, bronchodilation. But the most important thing to know is the side effects of the CNS stimulation, but it has additional side effects of seizures and dysrhythmias. That's what makes it very unique, because seizures and dysrhythmias are very unique to this one, along with the other the CNS toxicity drug that can occur. But this one has dysrhythmias right there. That's really big. So keep that in mind because this one is a pretty toxic drug, which makes sense, right? It's the last option. Beyond that, it's given a loading dose, taken with food. Do not crush like others. Watch caffeine intake because, again, built very similar to caffeine. And that's really it. And we could finally just finish up going all the way to the epinephrine chapter, like the epinephrine section, all the way down. Like how we could keep going. Honestly, we could just touch on only epinephrine because like all these other things, right? Okay, so here we are, right? So vasoconstrictors, right? Vasopressors and all that stuff. Epinephrine is basically a vasoconstrictor, and what we're mainly talking about is anaphylactic shock, right? So when a person gets anaphylaxis, right? What is anaphylaxis in definition, right? It's basically the immune system acting its worst at like peak function where it's basically killing you. Like, hey, you can't have an allergic reaction if we kill you, right? Because you won't be alive anymore. That's basically kind of how it's looking at it, right? So what happens is that histamine is released like crazy throughout the body, right? We said histamines are helpers to immunity, right? Histamines and so many different other white blood cells produce vasodilation because when we have like a local infection, right, we want vasodilation to occur because we want more cells to get to that site, right? That's why you get like redness and infected wounds because it has more vasculature. It's like dilated, so more blood vessels go in, so more white blood cells come in. That happens to an extreme level around your neck and it closes your airway. It doesn't close your airway in that specific way. It's more like kind of causing ischemia if you think about it, because right, so this is like a normal airway, right? And like pretend this is a mouth or whatever. I mean, bad drawing, but long story short, the like pretend this is a neck, right? So when you're having anaphylactic shock, these vessels are dilating so much that the windpipe is being basically occluded by inflammation. And this is the reason why, most importantly, when it comes to anaphylactic shock, the most pivotal drug to give first and foremost is epinephrine. Because epinephrine will, right, we said these are like blood vessels that are way too big, right? They're pushing on the neck. They're causing so much constriction. We need a vasoconstrictor like epinephrine that shrinks the vessel all the way down and it will open up the airway like how we need it. So the patient can now breathe, right? Obviously, epinephrine isn't the only solution. You also need to get rid of the problem. Because what's the problem? Is it the choking, your body choking yourself out, or is it the release of histamine? Which is the real problem? Not okay. So it is a problem, right? The choking, but we've already cleared this open, right? We gave epi. The patient has epi on board. So will that epi last forever? What is really causing the problem? The histamines are causing the problem. That's where you give, what did we say all the way in the beginning of the slides? It could be given IM or IV for severe allergic reactions. Benadryl, right? An antihistamine. Because that antihistamine will get rid of the problem. The epinephrine is the band-aid to stop the patient from dying from choking. But that doesn't remove the histamines that are causing the problem. So the patient needs first epinephrine, second Benadryl. Third, if their blood pressure is super low, they need crystalloids, normal saline. If their blood pressure is extremely low, They get colloids because that maintains the pressure heavily in the vessels. Because our blood pressure is our life force. If you get rid of our blood pressure, we basically die. So that's where you have to be mindful of this type of stuff. Biggest things, I don't know if it will come up in the test, but there is education that needs to be given for like patients with EpiPens, right? Never have your thumb over anything. Always have your freaking hand like this. Remove the safety, inject it into the leg, and leave it for I think 5 to 10 seconds. And other than that, I mean that's kind of it.